ladies and gentlemen. A very warm welcome to today's special of Sanofi Diabetes Dialogues, a series dedicated to exploring various aspects of diabetes from facts and fiction to myths and insights surrounding the disease and its treatment. Today's topic is debunking the myths, where we are taking a closer look at the most common misconceptions about diabetes, treatment options, and the broader impact it has on health and well being. This series is proudly brought to you by Sanofi India. Let's begin by addressing some very important and perhaps startling facts. Number one, diabetes is actually one of the fastest growing global health emergencies of the 21st century. It is a condition where either the pancreas does not produce enough insulin or the body cannot effectively use the insulin it produces. Now, insulin, a crucial hormone, regulates blood sugar levels. When sugar levels remain high, they can silently damage the body over time. Now, people living with diabetes are 2 to 3 times more likely to develop cardiovascular diseases such as coronary artery disease, strokes, or heart failures. And if left untreated, diabetes can eventually damage the kidneys, nerves, and other vital organs, and in some cases, lead to loss of vision as well. I know these facts are sobering, aren't they? But fear not, because today we are going to equip ourselves with knowledge and clarity, and who better to guide us than the distinguished experts in the field of diabetes. I'm your host, Mugdha Kalra, and joining me for today's discussion are two specialists, Dr. Om J. Lakhani, Consultant Endocrinologist, Department of Endocrinology, Zydus Hospital, Ahmedabad, and Dr. Manoj Chawla, Director and Consultant Diabetologist, Leena Diabetes Care and Mumbai Diabetes Research Center. Dr. Lakhani, Dr. Chawla, welcome to this very special show.
Thank you,
Hi,
Mugdha.
Mugdha. Thank you for having us here.
Well, doctor, it's hard to remember the last time I met someone who didn't either have diabetes or was pre-diabetic themselves or knew someone close to them who had diabetes. And it's become so common. Just to put things into perspective for our audiences, we all know that in India, over 100 million people are living with the condition. We are unfortunately called the diabetes capital of the world. And there are several studies that are coming out. Primary ones being Sanofi's landmark study found that even though there was a reduction in blood sugar levels, over 60% of patients couldn't maintain the target sugar control over a span of 3 years. And according to the International Diabetes Federation, nearly 1 in 2 adults with diabetes doesn't even know that they have it. Now, I'm sure you have more statistics than I do. You already know all of this. But Dr. Lakhani, if I may start with you, can you help me open this discussion with why is this situation? Is it because diabetes shows no immediate visible symptoms or there is more to it?
Yeah, it's a combination of few things. So to start off, we are genetically a little bit on the back foot as far as the risk of diabetes is concerned. So Indians, as you know, we tend to accumulate more of a bad sort of fat, the fat under the skin, fat in the, close to the organs of the body. And this is the fat which leads to, inflammation and leads to chronic insulin resistance. So that is one of the reasons, right, why we, tend to be at the back foot in terms of the risk of developing diabetes. Now, it was fine till an era where the food was scarce and it was limited. But now we are in the world where food is unlimited, right? So you don't have any kind of restriction to food. So, you have bad genes, and B, then you are, in a world where food is unlimited, right? So you have unlimited, food, mostly of quality that is not considered healthy. So this is what, as a combination leads to the epidemic of diabetes. And to be, the numbers sound staggering. The problem is that we are just getting started. These are just the early waves of a upcoming tsunami. It's going to be big. It's going to be huge. The number of children now these days we see in the teens who are obese, who are, already having the early signs of pre-diabetes. These children are going to become, diabetic adults, and, they're going to become diabetic parents, and then, they're going to go on, it's going to go to the next generation. So it's big, it's a huge number. And I think if we don't course correct, we are going to face a huge problem for the nation in the upcoming few decades.
To Chawla, as Dr. Lakhani mentioned, we know there's a predisposition. There are so many other lifestyle factors that are contributing to the rise of diabetes. To be honest, when I was getting my blood work done, or when I get my annuals done, that's when I figure actually whether or not my counts are up or high. And a lot of people and parents of younger children, as Dr. Lakhani also mentioned, figure these things out only when there is a manifestation that needs to be addressed by a doctor, or your results of blood work is indicating. And then you start to think, can this be cured? Can this be reversed? Can you throw some light on this? And can you also help us with the treatment options to perhaps manage it in time, or better, as soon as we get to know that we are perhaps diabetic or pre-diabetic?
Right, Mugdha. So, well, as mentioned, the diabetes tends to be largely asymptomatic. So, it's always been known as a silent disease. And to put it more dramatically, it's been known as a silent killer for the reasons that this condition will not always produce symptoms. There may be just subtle symptoms or none at all. And hence, probably the need for more universal screening. And as Om mentioned, that Indians are having a genetic predisposition. Today, when we talk about various screening methods, checking sugars isn't really expensive, and hence should be a part of universal screening, maybe in India from much earlier on. And we would say probably beyond today, 25 years of age, every individual should have their sugars checked every once in 2 years, if not more often. Now, as you also mentioned in your introductory statement, that IDF itself says that exactly the same number of people who have diabetes may yet not be aware or not be detected. So the ratio is almost 1:1, and that's why the need for picking up these individuals who may have either diabetes or pre-diabetes much earlier to bring about changes today, which may help in the remission of this condition and probably getting back into a normal glucose tolerant state. When you asked me about treatment options, though there are a lot of treatment options which have evolved over the last several decades, even today, the importance of lifestyle change continues to be right up there. So even today, when we talk to patients about their treatment options, we'll always be very clear that it's your lifestyle change, which means getting in enough physical activity or exercise, your dietary modification, attempts to lose weight, of course, through that, are going to be number 1 and 2, and then is going to be the medication which follows. So today, for individuals being able to monitor what's changed in the last few years or the last decade is the easier means of monitoring your sugar profile.
True.
So with the advent of continuous glucose monitoring, which is coming, you would have seen a lot of individuals today who are wearing the sensors on their arms or tummies, be it just people who are careful about their health, runners, health enthusiasts, marathoners, or those people with pre-diabetes or early diabetes are able to monitor, which makes them understand what aspect of their dietary choice or exercise or lifestyle modification is impacting the sugars favorably or adversely. So that, I think, is bringing about a huge change. As this condition is silent, and human nature being human nature, we all need a reason why I should do something and why I shouldn't. And that visible ability to see how everything is impacting my sugars is making a huge change. When it comes to therapeutic options, well, I think there are plenty. So we will typically, for somebody developing type 2 diabetes, beyond the lifestyle change, we would use oral medications, and being aware that at some point where oral medications may not suffice, right, which may happen along the course of this disease, which is progressive in nature, there are options today of injectable treatments, which are called as GLP or insulin. So these all form an important aspect of treatment, but it's always going to depend on the patient's levels, the other comorbid condition, their symptoms, where the treating doctor will guide in terms of, besides diet and exercise, what is the right choice of medication for that particular individual.
Right, Doctor. Dr. Lakhani, Dr. Chawla very eloquently spoke about the treatment options, the lifestyle changes that one may have to make, one definitely needs to make, and also a prescription of insulin in some cases. But there is this hesitation in a lot of patients when it comes to using insulin. And a lot of them always ask, is it for every person who is suffering from diabetes? Is insulin the only answer? How readily is it available? What's my dependency? Should it be introduced so early in the treatment? I'm sure you get as many patients who are Googling and coming back to you and giving you their own gyan on, how their treatment should be. But what is actually the course of action when it comes to insulin?
So I think, the first myth, Mugdha, that we need to kind of dispel, and this is a myth of the new age. I see this on Twitter a lot. You have this new age, health gurus who do not understand type 2 diabetes, who tend to kind of, downplay the role of insulin the role insulin plays in type 2 diabetes disease itself. So what happens is that, think of diabetes in two spectrums. One is, the pre-diabetic state when you don't have high sugars, when your sugars are fine, they are below a certain cutoff. And you have diabetes when your sugars are already on the higher side. Now, the difference between these two states is that on the pre-diabetic state, you have insulin resistance, but the body is able to catch up. The body is able to produce more insulin to catch up with this insulin resistance. So that's why your sugars remain, though your pancreas is under stress, it does remain under control, right? So you don't develop the blood sugars being high. But then the system breaks, and the insulin resistance either keeps going high, or the body is not able to produce enough insulin to match up with the insulin resistance. So it's like climbing a hill where you are able to climb to a certain extent, but if then beyond that you can't, and then you are tired, right? So sometimes you might even slip off and start falling back. So sometimes what happens also in some of these cases is that whatever insulin that was being produced, that also starts slipping away, and that's a state known as glucotoxicity. So when we see, and Dr. Manoj, we had this discussion, several times in the past as well. A lot of Indian patients with diabetes come with the later, right, where they kind of slip off from the hill. They're trying to climb the mountain, they suddenly slip off, right? So their blood sugars, when they first, they are first diagnosed with diabetes, blood sugars are very high. Blood sugars are in the range of 400, 500. They typically have the symptoms of diabetes, even though they have type 2 diabetes. So the problem really is that insulin deficiency is the core pathogenesis in diabetes. It's a core problem in diabetes. Now, when to introduce insulin should not depend on the severity of the disease. I think it's a wrong concept which has been kind of fed for a long period of time. It was always, that even now, if you see the guidelines, it's always been that, you start with, a particular drug, and then you add a second drug and third drug, and then you add an insulin. Unfortunately, that approach is a wrong approach to go about. What really you need to see in the modern world, where we are really looking at precision medicine, we are looking at the right fit, right medication for the right patient. You really have to see whether the patient has clinical signs or symptoms of insulin deficiency, or is the body really asking for insulin, right? So at that point of time, adding a second drug or a third drug or some other medication is not really going to help. The only thing that really will improve the patient is to add insulin, right? So gone are the days, where you just wait for the patient to kind of the pancreas to really get to a state where, insulin is not produced at all, to introduce insulin. There are certain situations where we introduce insulin early. In fact, a lot of my patients, there are a large pool of my patients whom, right at the first go, we have introduced them on insulin. We started them on insulin. And then second myth, which kind of correlates with this, is that people feel that, insulin once started cannot be stopped. Now, this is true when you introduce insulin too late, when you introduce it in a state where the pancreas is not able to produce insulin at all. Rather, if you timely, introduce insulin at the right time, it breaks that glucotoxicity. So it's like, again, I was saying that you're trying to climb a hill and suddenly you start slipping off. Now, somebody, maybe a colleague of yours, anybody's done a mountaineering, you have a buddy, you have a friend, right? You have somebody watching out for you, right? So that person who's watching out, he just pulls your cord, right? Or just prevents you from slipping. then you stop slipping, right? You get the strength again to climb again, right? So that's what happens, when you are slipping off, when you are in the glucotoxic state, insulin acts like your buddy, acts like your watcher, right? Who really pulls your cord, prevents you from falling, slipping further, right? And holds you in that position, right? And once you're in that position, you slowly climb up back to your original state, right? So again, at that point of time, you don't need the help of your helper again, right? You're back to, where you started. And same way, at some point of time when insulin has done its job, you can actually reduce the dose of insulin and stop it altogether. Again, there are a lot of patients of mine who we have introduced the insulin at the right time. We are able to stop the insulin also. And I think that's nothing more powerful than that, because you have done, a sort of a precision medicine. You're given the right treatment at the right time. Also, the patients, those fears and quote unquote, issues with injectable really go off, when they, they are off insulin. And very importantly, it's something they look forward to, right? So they say, they look great, I'm doing a good job. My sugars are well controlled. I'm sure you're going to reduce with the dose of my insulin. You're going to stop my insulin at some point of time. That's a motivating factor as well. So I think, I think the idea really is to use insulin instead of using it as a warning, instead of using it as a tool to, make people adhere to their medicines. I think rather use it strategically in a well-placed manner where the patient really benefits from a pathophysiological perspective, right? Where you get the right drug for the right treatment. At the same time, you save the pancreas, you prevent it from slipping further, right? And at the same time, the patient also benefits overall in terms of their overall blood sugar control. So I think that is how I really look at insulin in today's world. And I think, one more thing before I, finish this answer. One more thing which has really changed in terms of diabetes management, and this is quintessential for us to understand diabetes. And gone are the days again where you are actually treating to fail, right? That is what, again, the strategy has always been, that you start a drug, doesn't work, you add a second drug, doesn't work, right? You're treating to fail. You're just waiting for it to fail, right? That doesn't work. The problem is now a lot of studies have shown that the only way where you can really potentially prevent long-term complications is to have early aggressive management of diabetes. So right at the point where your diabetes has been diagnosed, you hit the pathogenesis, you hit the problems which are there, and at that point of time, then you taper off and tailor off the treatment, right? So that is how really, the best strategy works. And these are the patients who really don't develop complications on a long run, right? But if you keep treating to fail, they will eventually, the complications will catch up and the patient ends up where, with the situation where you really wanted to prevent.
Wow, that was some insight into insulin. I would have never thought about precision treatment and how insulin can be introduced early, and how it may actually show better results with the younger people who can actually have better outcomes, and then at some point in time you can taper it. But that definitely was the myth that you broke for me, Dr. Lakhani. And Dr. Chawla, if I may come back to some of the other myths that are surrounding insulin, what are some of the things that you hear from your patients? What are some of their fears? Now I'm understanding from Dr. Lakhani that obviously insulin is not the end game, from the point of view that if the doctors are thinking that insulin is likely to work better in this particular case, it will be introduced early, and that it can be tapered, and that it can be actually stopped if the results have been very good. But I completely understand it depends from case to case. Having said that, is insulin addictive? Also, what are some of the other myths? One of the other myths that I've heard about is that does it clash with any other medication that you may have to take in case of say another disease or another ailment? What happens then? Does it react all right? I mean, I'm sure many other myths that you would be coming across, sir.
I think it's not that we've heard all the myths yet. Every now and then we'll come across a stranger belief or a myth springing up. So life continues to be exciting and interesting in that sense. But yes, I think amongst the common myths, of course, some Om already mentioned about the feeling that this is, the end game for me. Am I being punished because I haven't really taken care of my health? Give me more chance. Give me a few more months, doctor. Blah blah blah. So that aspect continues. The other one, as you rightly mentioned, the belief is that if I take insulin once, I will have to take it all my life. And which very, very clearly is something that a myth that we try and bust, informing that yes, in many situations, we may decide to use insulin right in the beginning itself. When somebody comes to us with severe symptoms of hyperglycemia or high sugar, having lost weight, very cachectic or muscle loss, uh, these individuals, to overcome, as Om mentioned, glucotoxicity, will be offered insulin in the beginning, which is ideally the best option. In fact, many young people today, and India continues to have that typical problem of young type 2 diabetes, everything starting here not a decade earlier, but I would say almost 2 decades earlier than the Western population. For a lot of these young individuals who are looking at trying to so-called get into remission or reverse their diabetes and change their lifestyle, the use of insulin in the beginning period for a few weeks works the best for them to help their pancreas get some rest and then kind of get back into normal. So very often insulin is used for temporary periods. Yes, somebody who has it for a longer period, has kind of used all the oral medications, has it for a longer duration, we may continue to use insulin for them for a longer time. But it doesn't mean always that once you're on insulin, you have to be on it for life. That's one. The other myth is that it's extremely painful. Well, fortunately not. Today, with the advent of better devices and finer needles available, it is self-injection. We train every patient to take it themselves. It's easy to take it. There's nothing wrong they can really do with it. It just requires a basic training of where to take it and how to rotate the injection site and so on. The third worry on their minds is that once on insulin, my life is getting restricted. I can't go out
Right.
and eat. I can't travel. I'll have to carry ice packs with my insulin everywhere, which is again not required. So most of the insulin can be carried at room temperature without requiring ice packs. Whatever extra insulin that they may have will have to be stored in the refrigerator. But when they're traveling, well, insulin usually does not get spoiled at room temperature for almost a 30-day period. So during a travel, it is not restrictive. Wherever you may reach, you may then again store in refrigerated, especially in temperatures which are at extreme. But otherwise, most places, that's not a problem. The third aspect is getting, as I said, restricted. I have to take injection at a certain time before meals. Well, today, there are a lot of insulins that we use, which are usually given at a fixed time, very often at bedtime. So it's not that you are restricted and you can't have a social life and I'm bound by my time. Or if I just don't eat on time, I'm going to land up with my sugars crashing down. So the modern
Right.
insulins, the newer techniques, the better improvements in these medications have made a lot of these situations much easier, and that helps the patient lead a good quality of life without feeling restricted or bound. So aspects of pain, aspects of being bound, can't travel, have too much of a hassle bringing down, I think all are myths. Also, very often people feel that insulin is expensive, which is not the case at all. In fact, today, if one does an audit of what an individual lands up spending on their oral medications, and very often, purely out of desperation, that the individual wants to not get onto insulin and will request the doctor to increase their pills, their daily cost is actually increasing without getting benefit. And one shot of a standard basal insulin is not expensive at all. I mean, on an average, they will land up spending not more than probably 30 rupees a day on the
Wow.
insulin. So and whereas they may land up spending 50 to 100 rupees extra on multiple tablets. So it's not expensive. And does it also mean that I'm going to, if somebody would have seen their parent or grandparent in earlier days land up in hypoglycemia, which is low sugar
Right.
because of insulin, that fear is they live with that morbid fear that I'm going to require insulin and will have again limitations because I may just drop into low sugar. As I mentioned today, the improved insulins, the largely flatter basal so-called insulins, have a smoother profile with much lesser chances of experiencing hypoglycemia. Of course, every individual, whether treated with oral medication or insulin, as a doctor, we would train them to understand different symptoms. and also monitor their sugars regularly, whether they use a glucose meter or they use the continuous glucose monitoring device. So monitoring is
Right.
essential, but all these myths and fears largely purely by good communication can be overcome because the products have improved and we have better products available for patients today.
Dr. Lakhani, we have almost covered everything that we wanted to when it comes to insulin, the myths, how expensive is it, about hypoglycemia. Um, Let me talk to you about another aspect of it, which is what happens when I'm unwell. Do I need to stop taking insulin till I feel better? Does it clash with my other medications? What is my prognosis if I am looking at a comorbidity? What happens then?
So it's a great question, Mukta. I think, to start off, it's been more than 100 years since insulin was first discovered. Insulin was the first treatment which was offered for any form of diabetes, right? Whether, of course, it was initially designed for type 1 diabetes, but later on, there's an era where we didn't know the difference, right? But insulin, it's been more than 100 years since it's been there. It's outlived a large section of medications, right? Large section of modern therapies. Tell me another therapy which has survived the test of time for more than 100 years. Very few, right? So the reality is that insulin, is perhaps one of the mankind's greatest discoveries. Not only did it, change the lives of people with diabetes, it also opened up avenues for understanding other molecules, which now we use for different purposes, right? So that's I think one thing which is the testimony of the fact that it has lived for so long. Uh, the thing is that it's really safe. Apart from, the only problem with insulin, really, for me, I would say, is incorrect dosing, right? If you give the right dose of insulin to the right patient, it is probably one of the safest medications as far as the overall diabetes spectrum is concerned. So coming back to your question of whether you should continue your insulin when you're sick or when you're not, uh, I think the simple answer is absolutely yes. You should continue your insulin. In fact, when you're sick or you suffer from maybe some, maybe gastroenteritis or maybe some fever or other situations, there are other medications or other diabetic medications which, for some other reasons, we may have to discontinue. Or, for example, you may be put on some antibiotics. You may be taking some other drugs. You had asked earlier about the drug interactions. Some of these other medications can actually have drug interactions. Insulin is one which has very few drug interactions. Only thing, again, the disclaimer here is that the right dose has to be given to the right patient. So if you're sick, if you're not able to eat well, perhaps you need to meet your doctor again and or maybe do a teleconsult with him, and they can consider reducing the dose of insulin or maybe changing the dose of insulin. In certain situations, certain kinds of infection, something called as sepsis, or some more severe forms of infection. In fact, some of these situations you may require a higher dose of insulin also. So again, the situation may change, and it often depends on what disease you are facing and what is the consequence of that. So I think it's wrong to say that you will have to discontinue your insulin during any illness. Again, to reiterate this point, if anybody who's admitted to the hospital for any reason, maybe for surgery, or maybe you're having some other fever, or maybe having some other infection, the often, as a rule of thumb, doctors often stop all the other medications and put the patient on insulin, right? So it's the other way around, right? So that insulin is one drug which is very, very safe, easy to titrate. You can give doses anywhere from a single unit to maybe 100 units a day. You have that option of fine tuning it, titrating it, changing the nature of insulin, changing the insulin itself. So all these options you have with insulin in terms of flexibility, which you don't get with other drugs. So I think that makes insulin perhaps a very unique molecule. And I think, to cut the long story short, don't stop your insulin when you're ill, rather contact your doctor, and they'll probably guide you for the right course of action.
Thank you. Thank you, Dr. Lakhani, for that answer. Dr. Chawla, the last word is yours. Any parting thoughts on what needs to be done to lead a life which can be with insulin, but need not be as dark as you're thinking it is going to be. But I also want to bring up the point that you made earlier about that it is also about lifestyle changes, etc. So a combination of the two. Would that be your parting thought as well?
I guess so. So, it's been over 100 years to discovery of insulin, which continues to be one of the most important inventions in the field of medicine. And for many may not know this, that insulin was actually the first medication for diabetes, much before any of the oral medications were discovered and invented and produced. Today, of course, we've moved on with our understanding of this condition, and it's still evolving. For people with diabetes, or even for those without that, my message would be clear that let's be aware that as a race and as a generation, as a community, we are at high risk, and hence the need for early screening within the family and the community. For those getting detected with earlier, lifestyle change would continue to be the most important factor to stay healthy and to keep things under control and to prevent the complications of diabetes. For managing your diabetes, yes, in today's times, you have multiple options available, which you will seek your doctor's guidance for. And along with your lifestyle change, your doctor will guide you on the need for oral medications or insulin from time to time. But let's just remember that amongst all the options available, insulin continues to be the most effective or efficacious option till date. Even though advances in medical therapy have come out with various new oral medications, it's that one medication still which works the best in terms of ability to reduce sugars, and that is insulin. Diabetes largely continues to be about deficiency of insulin in the body or resistance to the action of insulin, and hence insulin will always be an important aspect in your treatment of diabetes, or an important armamentarium in your doctor's hand to treat you for diabetes. So let's not shy away. Whenever required and suggested by your doctor, the need for insulin, it may be temporary, it may be on a long-term basis. It is surely one thing which is going to help you get to control and target your numbers better. And of course, as a result, prevent the dreaded long-term complications of diabetes. An important thing to remember today is in the past, we would see our population develop type 2 diabetes in their 5th or 6th decades of life. So with an average lifespan earlier, which was anywhere between 60 to 70, you were looking at protecting an individual for 15, max 20 years without complication when they develop diabetes. Today, unfortunately, you have a lot of people developing type 2 diabetes in their 3rd or even 4th decades of life. Your average lifespan has increased to above 75. So you're looking at protecting that individual for almost 40 years without getting complications. And hence, it's time we understood the importance and role of insulin, which is going to be one therapy which is always going to be relevant and effective for every individual with diabetes.
Well, thank you so much, doctors, for all the wonderful insights and the reassurance as well. As we wrap up today's discussion, it's clear that while diabetes is a serious condition, it's one that can be managed with the right knowledge, tools, and support. Early detection of symptoms, understanding treatment options like insulin, and staying informed about the risk and prognosis are key to leading a healthier life with diabetes. Remember, managing diabetes is not just about medication, it's about making informed choices every day, whether it's through your diet, exercise, or regular checkups. And always keep in mind, you don't have to navigate this journey alone. Reach out to healthcare professionals, support networks, and loved ones to ensure you are taking control of your health. And to learn more about better diabetes management, please visit www.intolife.in. This is your host signing off from Sanofi Diabetes Dialogues. Stay well and take care.